Hi, good evening. Can you guys hear me?
Yes, thank you, Dr. Bana.
Perfect. And it's presenting well, huh?
Yes, we can see that you're sharing your screen.
All right, cool. Always got to check. I mess that up quite often. I think we'll just wait another minute and then we'll get going.
De jugar un partido con tus amigos en lugares era más que no tener zapatos, ¿sabes? A veces lloraba solo porque me frustraba, ¿no? De no estar ahí, estar lesionado y no poder mostrar mi talento. Y bastante, vamos a hacerlo de la mejor de la manera. Así que nada, algo muy bonito, agradecido a Dios por 21 salas ganadas en un día que no tiene precio de nada.
We can hear the whole conversation somebody's having. All right, let's get going. So we've got a big topic to cover today. So we're going to be looking at weight beyond diet and exercise. I've recently given a talk to a group of dietitians, and we spoke about the 5 pillars of weight loss. So I'm going to cover some of that. So I apologize for some of you that were at that conference, but we'll I've brought in a few case studies as well and a few other concepts. So these are my disclosures, and I just want to let you know that these are my thoughts in terms of possible ways of patients losing weight, and so they may not reflect what some of the guidelines say. And we'll go through why that as well. So there are many different factors that are associated with obesity. And there are genetic factors, there are environmental factors, there's a whole lot of disruptors out there that can influence hormones. And then there are certain endocrine conditions and drugs that affect it as well. So from a genetic perspective, your race matters. Certain ethnic groups are at a higher risk of putting on weight. Certainly family history. So we know people, children that have obese parents end up being more obese as well. Children that are overweight by the age of 5 are 80% more likely to be overweight adults. Then there are certain, and in most of those cases, it's a polygenic issue. However, there are specific genetic defects, like this particular one here, or Prader-Willi, that will lead to excessive weight gain. From an environmental perspective, it's important. So level of education has been linked to obesity, whether your employment status, neighborhoods. I mean, that's important in South Africa. Do we provide safe neighborhoods for people to lose weight? Is it safe for them to walk out at night? Are we encouraging walking and running and cycling as opposed to taking buses or cars?
Dr.
Council,
Bali?
yeah?
Sorry, we can't see your slides. We can see your general screen that has lots of slides on them, but we're not actually seeing the one you're referring to.
All right, so let me see if I can just go off again and come back on. Yeah, I'm sharing again. Is it better?
No, but you're getting messages in the chat. It says maybe you need to look at it in presentation mode.
Yes, I am in presentation mode. All right, let me just see it again. Share screen.
Yes.
Are we good?
We're good.
All right. So we were just chatting about the genetic factors. We touched on the environmental factors. And here, cultural background is important as well, because in certain cultures, especially in South Africa, we went through that phase where with HIV and TB, it was frowned upon to be thin, because one would then assume you had one of those two conditions. And so it's then difficult to convince people that they need to be leaner from a health perspective. Sleep, we're going to touch on that as my last slide. And then there's a whole lot of endocrine disruptions that can take place that can lead to weight issues as well. And then we all know about underactive thyroid and its influence. We see cortisol in its extreme expression causing weight issues. The gynaes amongst us know very well that polycystic ovarian syndrome, the basis of which is insulin resistance, ends up causing weight. And then many of our clients are on antidepressants, and most of them will influence weight. And then, of course, the excessive use of steroids and other neurological agents can affect this as well. So there's over 250 loci that have already been found on GWAS to be linked to obesity. So we need to start thinking out of the box. And for those of you who remember a bit of second year and third year medical school, or your pharmacy degree, or if you're into dietetics, in terms of energy balance, there's many pathways that are intertwined and linked in terms of getting one to manage the weight. And so this condition belongs to all of us. This is a quick slide showing you that there's over 229 organs, complications that get affected by obesity. And so we all need to somehow learn how to manage it a bit better. And then for those who write guidelines, for them, it's important to see if a condition causes mortality and morbidity. And here clearly it shows a correlation between BMI and the number of years you will lose. So for instance, if you've got a BMI of 30, you will lose 3 years of your age. And this was an analysis done with an average age of 54. If you're sitting with a BMI of around 40, you will lose between 8 and 10 years of your lifespan. So this becomes important. Now, lots of studies showing here that it's not difficult to lose weight. So anywhere below this line shows success in terms of weight loss. This is the percentage we're looking at from a kilogram perspective. So here you can't refute this data. So the problem is, once you lose weight, how do you keep it off? So this is data looking at just diet and how one can lose weight. So that's the need. That's showing you the need for pharmacotherapy. So why is it so difficult to keep the weight down once you've lost it? So what happens is, once you go on an energy restricting diet, what happens is, remember, from an evolutionary perspective, that was a bad sign, because that means you're not having enough stores. And so you have physiological responses to try and counteract that. And so what happens is leptin goes down, and that's a measure of your fat stores. So that's like peeking into your pantry and saying, oh, the shelves are looking empty. Yeah. So when leptin's low, the body is saying there's trouble with energy source. What's going to happen is your satiety hormones are going to go down. Satiety is a sensation you feel when you have enough to eat and you're feeling full. So you lose that so that you will start foraging and you'll generally then end up eating more than you normally would. And then, of course, energy expenditure goes down. So in the extreme setting, we see this with hibernation in some animals, but something similar happens to humans as well. So the net effect of leptin stores going down and satiety hormones going down is that you start feeling hungry and there's a desire to eat, and then you go hunting and you go looking for food. And once you find it, you're going to forage and you're going to generally eat a bit more than you usually would. So this combination of wanting to eat more and conserving energy, the net result is you're going to get the weight back up. And the energy reduction happens at a mitochondrial level. And what happens is you decrease your T4 to T3 conversion, T3 being the metabolically active hormone. So just a quick look at what all the guidelines talk about. So there's the Canadian one, and regardless of who you are, what your size is, everybody should know and maintain a good body size, composition, and we should all be eating well-balanced foods and having regular exercises. So it's not only reserved for somebody who's already got a problem. This speaks to prevention. It's important to recognize at all levels, doesn't matter what BMI you're sitting with, look at the 5 different categories, you need behavioral modification because food, we're wired to be addicted to food because it's a survival thing. And then pharmacotherapy comes in with BMIs above 27 with comorbidities, or BMI above 30 without comorbidities. And then today is not our day to talk about surgery, but that features in a lot of the guidelines as well. So we've been shown recently, because there's new pharmacotherapies available on the market that speaks to the brain. And so we are all, at the moment, most health practitioners think the only way to get somebody to lose weight is to work on this aspect of obesity. So homeostatic eating is when we eat for hunger. Like every other animal in the kingdom, we've been wired to look for food and eat to survive. And so what guides that pathway? It's these hormones. So hormones in the foregut, GLP-1 receptor agonist, polypeptide Y coming from the foregut as well. Here we've got oxyntomodulin, you've got POMC, amylin. All of these work in one way or the other to increase satiety. So what it does is it tells you, I'm full. And so you end up eating less. And then ghrelin, which is also in the foregut, works by increasing your hunger. So it's a balance between these two that will guide how much we're going to be eating. Then there's another part of the pathway in the brain we call hedonic eating, and it's eating for pleasure. Now, humans are one of few species that will actually eat for pleasure. We socialize around it. There's tastes, there's memories linked to food, what our grannies cooked when we were young and we were happy. If you look at, I always use this example, if you look at Lay's, the amount of money they spent on the crunch factor, on crisp, to make it addictive, all of these factors playing on this part. And that's driven by dopamine, which is the reward center, the wanting to eat, and then the opioid and cannabinoid parts of the brain are the liking, the pleasure part of food. And then comes in executive function. So at the end, you still need your higher functions to say, okay, regardless of whether I feel hungry or not hungry, whether I'm satiated or not, I will make a decision to eat or not to eat. So there is still a system that overpowers all of this. This is just looking at the pathway in a more complex way. I'm not going to harp on these. A lot of you guys know how the GLPs work, and they work through these pathways as well. Again, these guys work on satiety and decrease appetite, and these guys, and the negative feedback on this on the agouti-related peptide and neuropeptide Y pathways will work on hunger and increase appetite. So you've seen those in a lot of talks. So then we come to what is officially, and this is probably one of the most progressive algorithms. So the Canadians are far ahead of most other countries in terms of managing obesity, and actually the government pays for treatment, provided your BMI is above 30 or above 27, and you've got obesity-related comorbidities. And so the algorithm then goes either to your left or to your right. And how do you decide whether you're going to go to the left or right? You're going to look at comorbidities and specific features. So if you got a client who's diabetic, pre-diabetic, hypertensive, obstructive sleep apnea, polycystic ovarian syndrome, looking like they've got the metabolic issues, then you move to the left of the guideline. However, if you've got a client who's overweight, but more of craving issues, more of addictive issues, depressed, smoking, then you're going to try to go to the right of the guideline. But before you move there, always consider and say, what is it that you can change in the patient's medication that will prevent them from putting on weight? For example, if you had a patient with type 2 diabetes and they were on an SU, and SU is more likely to make them put on weight rather than in, let's say, an SGLT2 or a DPP4 inhibitor. So if you've got a client who's on an antipsychiatric drug that is causing a lot of weight, speak to the psychiatrist to say if they can go on to one that is more weight neutral. You've got a rheumatologist who's gone crazy with cortisone. Negotiate, because otherwise you're on a losing wicket. So if you're more metabolic, you're going to go to the left, and this is where liraglutide becomes your first choice of treatment. That's your GLP-1 receptor agonist, and that works on hunger and satiety, and hopefully your client will lose weight, and we're going to touch on that. If it doesn't work, or it's working after 3 months, but you haven't got sufficient enough results, you can either discontinue, or if you've got significant one and you want more, you add a second agent. And the second agent will be a combination of naltrexone and buperon. In this country, it's called Contrave, and in this country, that one is called Saxenda. And then the third option is Orlistat. So the Canadians say, well, if you've got an addictive nature, if there's an element of depression, if you're a smoker, rather start with Contrave as your first choice. If that doesn't work, go on to Saxenda. If that doesn't work, add or go to Orlistat. So remember, you have to give it a 3-month period. And so the key messages to pharmacotherapy is that one needs to realize that there's an individual response, and that pharmacotherapies can have a heterogeneity. In some people, you can lose 5 kilos, and others 10. And that the response will be different from patient to patient, and then choose a drug based on its mechanism of action, safety profile, side effects, contraindications, drug interactions with other things, and mode of administration. In other words, individualize the treatment. So let's start with the oral treatment that is available in South Africa, Contrave, right? So it's a combination of naltrexone, which is a drug that's been used for over 20 years by anesthetists, and then buperon's been used for over 20 years by psychiatrists. And somebody in Australia found that this drug and that drug, when combined on lower dose, will act on the brain at the hunger and reward center. And after 3 months of using it, you can get, if you get 5% weight loss, then continue, because the potential is up to 11% after a year or 2, and you can use it for long periods of time. So it's sustained effect. You don't lose the weight loss effect, and it's been shown to be metabolically better for the patient. So the HbA1c's drop, cholesterol drops, waist circumference drops. So that's your oral agent, and its mode of action, I told you, it works on appetite by working on the POMC pathway that I showed you earlier, and then on the rewards pathway as well. And these two drugs work synergistically, so it's an additive effect, where the net effect is reduce cravings, reduce hunger, increase energy expenditure, and it promotes satiety, so you feel fuller on less. And this is showing you, compared to placebo in the gray, what's happened to a patient on Contrave over a 56-week period where you've lost weight. And what's important to know with every drug is that you're not going to get the same predictable response. So this shows that on this combination, about 80% of your clients will lose 5% after 3 months. About 55 will lose at least 10% of your weight. Then about a third will lose at least 15% of the weight. So it's a variable response. And if you combine it to behavioral modification compared to no behavioral modification, you can see there's a big difference, right? So the more active you are, the more you watch your diet with these drugs, you end up losing more weight. So more people will lose 5%, more people will lose 10% if behavior is adopted as well. So how do you take the drug? For the first week, you just take one every day, best taken with food. The second week, take one in the morning, one in the evening with food. Third week, two and then one, and then two and two, and then you carry on. And these are some of the contraindications. You can Google this, look at the leaflet. I'm not going to spend too much time on it, but with every drug, there's contraindications. So it works. What about your GLP-1 analog? I'm just going to give you about 3 slides on this and then move on to some of the more interesting parts. So this is a GLP molecule analog. So it looks very similar to the one that you and I have in our bodies. Endogenous GLP has got a very short half-life. The pharmacological ones, which are much higher dose, and they've been adapted on that particular amino acid, has increased its half-life. And so I'm not going to go through it in details. A lot of you guys have been to the launch of these products. They've already been on the market for the better part of 8 to 10 years, but it has a multifactorial effect. It works on the pancreas by making the beta and alpha cell work better. Better relationship between insulin and glucagon. It has an improved cardiovascular benefit, drops blood pressure, improves cardiac function, gets the heart to use ketones, decreases inflammation, works on satiety, decreases gastric emptying. So you release the glucose or the digested food slowly. So you decrease the glucose excursion. And then very clever workings here in the liver, where it improves insulin resistance and decreases lipotoxicity as well. So how does this guy work? We come back to the same pathway in the arcuate nucleus. It works by activating POMC and CART, so it improves satiety and you feel full, so you don't eat much. It works on neuropeptide Y and a agouti-related peptide that gets hunger down-regulated, and so you don't feel like eating, and so the net effect is appetite goes down and you lose weight. So the proof of the pudding was years ago, before it's launched, when you infuse saline as opposed to GLP, this is what happens. You lose weight. Against placebo, nothing happens. So this was on mice. And then it's been shown to work on many dimensions of appetite. It decreases satiety. It works on hunger, makes you feel fuller. And then it even decreases your prospective foraging. So it starts influencing your next meal. Okay. And it also makes you choose better food. So in mice, they had an option of eating candy or the normal boring food chow, and you end up eating less candy on liraglutide and more chow than the control. And then this slide's important, but I think there's probably going to be new data coming out, because just yesterday in the morning, I read how they think liraglutide does work on browning of fat tissue by influencing the mitochondria. It came through on Medscape yesterday, some early work from UCLA. So this slide may change, but this shows that basically it doesn't increase energy expenditure, but rather reduces intake in terms of calories. But watch that space. Now, it doesn't matter what product you use and what guideline you follow. All of them say that whatever drug you're going to use, you must have at least 5% weight loss in the first 3 months. If you don't, abandon ship. That means that's not the pathway that's causing the weight issue. However, once you get more than 5%, 5 or more by 12 weeks, carry on, because you're on the right track here. And so this is the number of responders you'll get on liraglutide. So about 2/3 will have weight loss on liraglutide, whereas 1/3 you're probably going to have to abandon ship. And that is a lot higher than the placebo group. And so this is just showing you graphically that over 56-week period, you lose weight as you go up from 0.6 to 1.2 to 1.8 to 2.4 to 3. The weight loss is more. And then here, like the Contrave, you get responders and non-responders. So 88% of people using this liraglutide will lose more than 5%. Half, 55, will lose more than 10%, and about a quarter, 15%. So the products more or less similar. What else is available throughout the world? So we've got Orlistat. That works not metabolically. That just prevents the client from absorbing fat. So in other words, you're passing it out. The stools are going to be more foul smelling. They're going to float, and then you can have some social mistakes on that particular product. So you're basically just wasting the energy by not absorbing it. Phetamine, basically appetite get reduced, but I've seen it influence the adrenal gland in some patients as well. They end up being a bit burnt out. These are the two drugs I've spoken about, and these were withdrawn off the market. But it's important one day just to go and read about them, because you can understand where they were working. The reason why they were withdrawn is because this one increased suicide rate and cardiovascular issues, and then this one wasn't shown to have cardiovascular benefit. So simple. In the past, we thought what you put in and what you burn is what you're left with, the balance. That is a very old thought now. They've put that one to rest. And so I think one of our future webinars is on the gut microbiome. Those of you who've heard me speak about this before, close your ears, because you're going to say, not this bloody example again. For those of you who haven't been on these webinars or my previous talks, the proof of the pudding for that one is they've done some mice studies. What they found is they took OB mice. These are mice that are bred to be obese, and from the same litter, that means they share the same genetics, put in the same cage, given the same food, forced to do the same amount of activity, so it's matched. And of course, these guys will put on weight. What they did was they ended up storing one of the mouse's stools, and then what they did was they got a thin mouse, took its stool, and inoculated one of the fat guys. And what happened is, with the same exercise, same diet, same food, same environment, the one continued to put on weight, and the one that got a stool inoculate from the thin mouse became thin, eating the same food. So they showed that the gut microbiome can influence the absorption of calories by up to 30%. What was interesting is when they kept the fat guy's stool one side. When they re-implanted that stool into him, he put on weight again. When they took some of that stool and gave it to the thin guy put on weight as well. So that throws this whole energy intake and expenditure story away, and that there's a lot more to this than just calorie intake. I'm not saying calorie intake is not important, right? Quality, quantity, all of that matters. But gone are the days where we can blame our patients to say, you're eating too much. There's patients that come to you. They come to you with photographic evidence where they WhatsApp photograph all their meals. Dietitians do it to follow their clients' footsteps as well. And some of them don't lose weight because keep an open mind because of what I've just shown you. So there's many other organs other than the hypothalamus that plays a role. Adipose tissue, the pancreas, the foregut, genetics, meds, and then I would add a whole lot of other things. And I'm going to do that because we need to understand the human body is an evolutionary product of marvelous physiology, and this entire physiology is conspiring for two prime directives. One is survival and one is procreation. There were no taxes to be paid 100,000 years ago. There was nothing about buying a diamond ring for your spouse. There was nothing about decorating your home. There was no issues in terms of going to work and becoming a doctor or a plumber or whoever. There was just hunting, gathering, and mating and procreating. That's it. And so all your hormones are conspiring to achieve these two things. It's survival and procreation. And in order to do this successfully, you had to have a good energy storage solution. And so it goes beyond the hypothalamus. We know thyroid plays a role with weight. And we know that because we see people with an underactive thyroid put on some weight. Some put on 2 kilos, some people put on 20 kilos, but on average, it's about 5 or 6. So you can't really always blame it for the extremes in terms of weight issues. Thyroid antibodies play a role as well. High antibodies has been shown to decrease deiodinase 2 activity. That's an enzyme that converts T4 to T3. The adrenal gland, so we see it in the extremes, where when cortisol levels are high, like you take a lot of cortisone, or you're depressed and your cortisol levels are high, or in Cushing's, these clients put on weight. And then as a defense system, when it's too low, it will hold on to the weight. Androgens, we see this in males, or we see this in children who haven't gone into puberty. So they're 16, they're 18, puberty hasn't set in, they're lacking testosterone. These kids will be chubbier. You give them testosterone or you induce puberty and they lose the weight. We see this in adult males as well. So testosterone, very important from a lean body mass perspective. Estrogen progesterone ratios. So we see estrogen is an anabolic product for females. I mean, in pregnancy, estrogen is what goes up and you start putting on this weight to get ready in case you're going to have to carry this child through a long winter. You need to have enough nutrition. The ratios are important as well. That speaks to apple shape and pear shape. Growth hormones. So some of you have seen patients with acromegaly. In the extreme of growth hormone excess, we see insulin resistance. We see in children who are short, don't have growth hormone, they are short and overweight. As soon as you give them growth hormone, they start becoming lean. So these are examples that we see in medicine in extreme cases where these hormones are playing a role with weight. Insulin resistance. Insulin is an anabolic hormone. Once you become resistant to it, it starts going up. When it goes up, it makes you put on weight. You'll see some of the guys are not meant to, but in the gym scene, some of the guys inject short-acting insulin with a lot of glucose, and because it's one of the strongest hormones when it's given in short pulses to build muscle. And so, of course, some of them have lost their lives. You can Google it. You'll see people have been found dead because they novices. They don't know how to use the insulin. They shouldn't, and they don't know how to use it. And then they get hypoglycemia, and they're always doing this in their private residence, so they don't get caught out, and nobody's there to save them from hypoglycemia. So that's been reported many times. Fatty liver, we're going to touch on. Polycystic ovarian syndrome, and we mustn't forget what's coming around the corner. So mitochondria, browning of fat tissue, the uncouplers, all influence are all going to cause weight loss. Drugs that are going to specifically work on this particular gene. GLUT4 in the muscles. Amylin. It's going to be one of the triple peptides that is going to be attached to GLP and GIP already on the market. And then gut microbiome, I've touched on that. So I'm going to now go beyond guidelines. I'm not saying, remember, guidelines are guidelines, they're not protocols. So I'm not saying you got to go against it. I'm saying for those of you who are interested in the field of obesity, think out of the box. And so there are many autoimmune states, and it matters in rheumatoid arthritis what your antibody status or number is. It matters so in lupus as well. So why do we ignore antibody counts in Hashimoto's and in Graves'? It's probably because we can't influence it, right? Modern medicine hasn't come away, but you can see the biologicals are coming into the scene, and that might change. But any autoimmune condition, one needs to understand that the doctors are going to be using products for these conditions that are not going to be good for you and your client, because weight is going to be an issue, right? So they use cortisone for this. They use cortisone, injectable or oral or topical, for eczema, for multiple sclerosis, and certainly for the ones on the second last slide. So here's case one. In terms of, besides getting the thyroid better balance, and I normally aim for levels of 1 to 2. So this would be a perfect state for that particular patient. Keep in mind that there's always a flux. They shop around, they move around, or other hormones change, and it can influence thyroid hormone. But the key thing here was we used a product to influence the antibodies. So here you can see the client having anti-TPO above 500, and over a period of time, it came down. Now, this is important to influence the T4 to T3 pathways. And we did that by using a product with high doses of selenium. So 200 micrograms has been shown in a big European study to influence antibody levels. This particular product has Google extract as well. It is a supplement from the Far East, and it's been shown to improve autoimmune state. So basically, any antibody, it's not restricted, like selenium is not restricted to just thyroid antibodies. So it's important that when you start with a client who's got a weight issue, you need to establish whether their thyroid is working well or not. So if there's no thyroid issues, TSH is within range, you know they got no pituitary issues, there's no family history, antibodies negative, don't pursue thyroid. That's not your problem. However, if you do have a client with a thyroid problem, make sure a shit level like this, no matter what you throw at the client, they're not going to lose weight. If the carburetor is not working, if your Mustang is firing with 4 pistons instead of 6 or 8, it ain't going to happen. So you got to correct that first. So here's a client with a TSH of 52, and then it was adjusted. The treatment was adjusted, and then it became much better, then went off again, and then slightly overactive. But what was important was that we had to adjust the treatment, and we worked on the antibodies as well. And so making sure that the thyroid works well, works better for the patient's 36 symptoms that are associated with an underactive thyroid, but also it's going to help the client if they came to you for weight issues as well. So it's important to keep in mind, and some clients will tell you when that antibody goes up or down, they don't feel any different. Some will tell you they get a feeling of fullness, they feel a bit more tired, they lose a bit more hair. So it's a very heterogeneous thing. And people will say, but don't worry about the antibodies. It doesn't mean anything. I think that is the story you and I would like to use, because we can't influence it. There's no pharmaceutical drug that has been shown to influence it, because we don't say the same when a patient comes to you for rheumatoid arthritis with their RA antibody sitting at 300 as opposed to 50. Then we adjust the methotrexate, then we adjust the biological, then we adjust the cortisone or the plasmaquine, because we can. So there we tell them the antibody does matter, whereas in this one, because we can't influence it so well, we tell them, don't worry about it. So I said you must watch that space in the future, because that is important. But for me, it's important because of what it does for T4 to T3 conversion. And then just touching on T4 and T3 conversion, about 13 to 26%, 27% of people world over may have a problem converting T4 to T3. There's different studies. So guys in Korea have studied this, the guys in China have studied this. Few countries have studied their population and have shown that there's a variable genetic response in terms of conversion of T4 to T3. I see it big in my practice when a client has had their thyroid removed for cancer or for nodules of goiter. Quite a few of them, or a larger percentage of those patients, have a problem converting T4 to T3, because our textbooks say 90% of what's produced in the thyroid gland is T4 and only 10% is T3. However, in some patients, there's a lot more T3 being produced there. And so when you take the gland out, they definitely have low levels. Most of us rely on the peripheral conversion of T4 to T3 at a cellular level. So now let's touch on cortisol, the importance of cortisol. So here's a case study, and there's many aspects to this case study. So for now, just concentrate on cortisol. So here the client comes to me with a low testosterone, high estrogen. There's a male patient. So aromatization of testosterone to estrogen. The DHEA for this client at this age was low, but you can see the cortisol low end of normal as well. So for all intents and purposes, the reference range here was 112 to 535. So closer to the lower end. And you can see there were other issues as well, thyroid and vitamin D. So we first needed to work on the thyroid, get the carbureted or the DB board working better. But we know that when the cortisol is too low, when the patient is burnt out, they're not going to lose weight. They're going to hold on to it. It's a survival thing, right? It's a hibernation thing. I need vitamin D to be good because it's a precursor to a lot of the hormones, but also very important from an immune perspective. It's important as a precursor to hormones. It's important for bone, and 8 is a very bad number. And so now, for now, we're just going to concentrate on cortisol. So when the cortisol is high above 535, we see it in Cushing's, it's going to make them put on weight. We see it in people who've taken a lot of cortisol. And so I aim in my practice between 6 and 9 a.m. in the morning for levels between 250 and 350. You want to be in the mid-range on the morning level. And then what happens is typically when your client has levels above 350, they'll tell you they feel a bit more tired in the morning when they wake up. They feel like a bus hit them. And incidentally, one of you guys have got your speakerphone on. And then
Dr. Barney, you're on mute.
Sorry, somebody else muted me. It's the second time, but anyway, thanks. So when the cortisol levels are high, the person will tell you that if you ask them, they'll be a bit more tired in the morning. They have energy dips typically between 2 and 4 in the afternoon. And the earlier it comes, the worse off they are. And if once you start treating them and the dip moves from 3 o'clock to 4 o'clock to 5 o'clock, the adrenals are getting better. They'll also tell you that they have supper, and then you'll see they'll still feel like nibbling. What they nibble on doesn't matter. It may be a fruit, it may be a biscuit, it may be a little sweet, but that's a survival instinct as well. You need to go and forage. It's a stressor. So when you get that, you've got to get your client to change their lifestyle. They're a bit too stressed out. I use adaptogens. If the DHEA is low, I push it up because DHEA, it's called the DHEA cortisol steal syndrome. When you're stressed out, cortisol goes up, steals the DHA, drops it, the ratios drop, and that's a problem. If DHA is and the adaptogens are not enough to get your cortisol normalized, and here the adaptogen I use is Solal's stress damage control. And so if it's above 500, I use one in the morning, one in the evening, between 4 and 6. But if it's above 350, but less than 500, I just start off with one. And then I correct the DHA. And if that's not enough, then I add pregnenolone. Pregnenolone is second best at bringing down cortisol level. And if that doesn't work, you use a product called phosphatidylserine. Bloody expensive. Few companies make it. Comes in 100, 300, and 500. But these are the ways you're going to influence the adrenal gland. Now, if you're sitting burnt out already, you need to work out why. So we know when our patients take cortisone, it's going to suppress their own cortisol level. So that's the first cause. The second cause is when there's a problem with gut microbiome. There's no published work on it. I've been doing this from 2003. That's the patterns I've seen. When I've excluded everything else and this guy is low, I work on the gut microbiome and I get that guy to go above 250. And that's working on the cause. This is working on the cause. These are quick fixes, but they're not getting to the bottom of the problem. But as long as the cortisol is below 250, you're not going to get that client to lose weight, even if you got them on a GLP. They're not going to get their full potential. So here I use burnout. Now, for those of you who don't like stress damage control, there's products called Stress Less. It works less better, but does work. You can just use ashwagandha on its own. It works. It's an Asian adaptogen, but a bit weaker. Licorice works over here as well. So read around these topics. Cortisol is important. Remember, it's a flight and fright response. Remember, 100,000 years ago, when there was no taxes to be paid, your only stressor was that another villager was going to come and kill you, a lion's going to kill you, or you're going through a long winter. You better store. That's what cortisol's there for, not for the tax man. And you see this with hibernation. You see it with bears. You see it with squirrels. This allows them to hold on to the fat as long as possible, and by down-regulating the metabolism. So this is important. Some of you may ask, now, how the hell did I know this? Before I became a doctor, I did BSc in genetics, physiology, and microbiology. That's where my interest comes in animal physiology as well. So this is important. Now, here's a case study. So just know you've seen some of my other bloods, right? I've just shown it to you now. We do a lot. We're not going to just look at cortisol in isolation, but today when I show you a result in isolation, know that, oh, here's it. I've got this case study. So I'm going to be hopping up and down. So this patient is 45 years of age, female patient, and came to me with lots of issues like all patients do, 44 years of age. And she had come to me because she was 85 kilos. And I asked her what her weight was when she was 18, and it was 50 kilos. And she had lots of complaints. She had a miscarriage, fertility issues. She had a DNC before. In her pregnancy, she put on excessive amount of weight, 22 kilos. She was on Trastan. She had a dorsal cervical hump, a short neck, which means more snoring, more sleep apnea, and wara. Anyway, long and short of it is, I worked on all the common things we normally do. We sorted her iron out, put on vitamin D. She was DHA was a bit low. Estrogen, progesterone was an issue, and we had her on GLP, but we were not getting the results we normally get, right? But this was one of the issues. And so, and remember, she was by somebody else before she came to me as well. So here had a low cortisol level, and we slowly started improving, and that's when the weights shifted quite a bit. So she went from 85 to 71. So for those of you who do maths, that's more than your normal 10% that they talk about with your GLP, right? And so that's why I said sometimes you got to look, because the patients have multiple effects for their weight gain. Here it was a bit of estrogen dominance, and there was a bit of insulin resistance. But the key thing that was missed by a few of the other colleagues was what was happening with the adrenal gland. We had to work on the gut microbiome, and we got that one to work a bit better. What about the role of sex steroids? So we come back to this case, right? So same thing here. We got that patient to have a better cortisol level by pushing the DHA up, working and getting that ratios good. Can see we pushed the vitamin D up. I aim for levels of 50 to 60. My level that I target is based on what we're dealing with. And then you can see we got the thyroid a bit better. But here, it wasn't until the testosterone came up that the client was able to convert fat to muscle. Yeah? And then remember, these patients have a higher body percentage fat, which then affects the whole axis, and it affects insulin resistance as well. But here, the important thing was the sex steroids matter. It's not only testosterone, because if you don't drop that estradiol level, the body, remember, females have a higher body percentage fat for a reason, right? Long winter, you need to hold the pregnancy through. And so in your female clients, it's always a bit more difficult to get them to lose weight. But this was a male patient. So if their estrogen levels are up, you've got the same problems like you would have in a female. You will have difficulty in getting them to lose weight. So we brought the estradiol levels down. So what kind of androgens are available to you to try and influence whether it's their sexuality, whether it's their weight, whether it's whatever? So you can use transdermal testosterones or the injectables. The transdermal testosterone, you got Androgel, which comes in little sachets, about 700, 800 bucks. It's 1% gel, and you apply it on your arms, on your thighs, and the testosterone will go up. Or you can use a transdermal cream, and there's 3 compounding pharmacies in South Africa. I'm giving my allegiance away here, but it comes in different percentages. So unlike Androgel, this comes in for females in 0.25 and 0.5, or you can then compound a higher dose if those were not enough. And then for males, 2.5, 5, 7.5, 10, 12.5, and 15%. And it works, but it has to be taken on a daily basis. And then you get the injectables, and then there's quite a few clinics around Johannesburg that run themselves as male clinics, and they'll tell them, no, we got a very special testosterone that nobody has, and then you got to go in there once a week or once every 3 weeks, and they inject you. There's no special testosterone. Testosterone's testosterone. The reason for that is that it's a bio-identical testosterone. Every company uses the same thing. That's why it's measurable when you do the blood test. The ones that are available on the underground are all anabolics, non-bioidentical. That's why you can't measure them. And they come with their own trouble unless they use responsibly. But from that perspective, depo-testosterone, Sustanon, and Nebido has the same testosterone. The oil emulsion is different to change the half-life. So this is a weekly injection, but I've had patients use it every 5 days, every 10 days, twice a week. It's a very patient individualized thing. The way to work out whether androgens or testosterones are working, you want a trough level. So once I start using the cream, a month or 2 later, I look at the level and I look at the testosterone, estrogen ratios, and we titrate it until the patient's happy. With the depo testosterone, these things work. We know they work. There's no point in looking at your blood levels the day or 2 after the jab. So if this is a weekly jab, traditionally, after my 3rd jab, they don't come in. I just tell them, look at your trough level. So if you are always injecting on a Monday, do your bloods on Sunday. We want to see, is it working enough? Are your levels still above 15? If it is, carry on. If it's too high, your upper limit is 27 and you're sitting at 30 the day before you're going to inject, spread the injection a bit further. Instead of every 7 days, 10 days. And then you find a way. Sustanon. Every 2 weeks, most of my patients only need it every 3 weeks. Again, after the 3rd injection, look at the trough level. Adjust it. You always want it above 15. but not too high. And then libido, every 12 weeks. Some people need it every 10 weeks. Some people need it every 14 weeks. Most every 12 weeks. Again, look at the trough level and adjust. For another day, make sure the prostates are fine. Keep an eye on the hematocrit because it will increase. And so they might need to bleed themselves annually or biannually to keep that hematocrit in a safe level. So these can be used safely. Remember, you give a male patient testosterone, it's going to act as a contraceptive. Make sure. I had a 24-year-old last week given testosterone by the T clinic, and the patient wasn't told that it's going to affect their fertility. So that is very irresponsible, but you're going to get yourself sued. So from that perspective, make sure the patients finish with their family. Otherwise, there's other ways of getting it up, which is a talk on its own. Now, this male patient had an estradiol level of 168. So how did we drop it? This particular client wanted something natural, so we went for estrogen balance. It's got I3C and DIM. You can see in good levels if you take 2 capsules, 2 tablets, and it drops your so it drops the estrogen levels, but it also decreases estradiol to estrone. Calcium deglutarate prevents estrogen in the gut to be metabolized to an active form, which will get reabsorbed, because remember the deactivated form is passed out through the bile. However, the gut microbiome can reactivate that estrogen and it can be reabsorbed. So that's where calcium deglutarate works. And you've got a good dose here. And then the sulfurans improves the improves the estrogen progesterone ratios. It's one of the highest sulfuran doses. And so from that perspective, and it's got a bit of TMG in it as well, and methionine. Be that as it may, you saw the level, the patient's level came down to, I think it was 68. So here's another case study. In terms of improving, there's a female patient now. Too much estrogen, 125, too little progesterone, imbalance. That's going to cause weight issues, the middle spread. After using the same product, we got a better balance. And so this patient complained of breast tenderness. Now we went through, some of you guys have been to the estrogen talk, right? And some of you haven't. So let's just touch on this. So estrogen dominant female will complain of breast tenderness, water retention, mood swings just before the cycle. They may even have breakouts in the chin or the T-zone. They will have the middle spread. Some of them will complain of pigmentation around the perimenopausal state. Some of them will have a history of fibroids or endometriosis or first trimester miscarriages or lumps in the breast. These are all features of estrogen dominance. Estrogen dominance is when the estrogen is too high or the progesterone is too low, or the estrogen is fine, but the progesterone is too low. It's a ratio. Nowhere in the textbook is such a high estrogen level normal, but gynaes like it to be measured in day 3 and day 21. However, you can look at it anytime, provided the ratios are fine. And so here, this high estrogen was not caused by ovarian cysts, orthocomas, or anything else. Estrogen dominance, thyroid was fine. And so it's important to take a good gynecological history or obstetric history, because it speaks to whether the patient is estrogen dominant. If they went on a low dose contraceptive like Years Plus, Clara, Soli, the Evra patch, and they put on weight. How do you put on weight on a low dose contraceptive? It's because they were so estrogen dominant, the contraceptive wasn't enough to switch the estrogen off. So now you got 2 sources of estrogen, the patch and the client. That's why they put on weight. That's why they have breakthrough bleeding when they're not supposed to bleed. And so pre-pregnancy history is important. Did they have difficulty in falling pregnant? And what post-pregnancy. So when you get them back, you say, well, listen, how much weight did you put on your pregnancy? 8 to 10 kilos. Okay, that's fine. However, they put on 20 kilos. Must have been a problem. Either an estrogen dominant issue or insulin resistance. So get that history, all the premenstrual symptoms. We need to be looking at it, because how are you going to manage them post-menopausally is important and based on how they wired. You give somebody who's estrogen dominant as much estrogen as they need to get rid of hot flushes and night sweats, they're going to be a balloon because they've been used to a high estrogen level. So you're going to keep going up on those patches or on those tablets to get that hot flushes sorted, and they're going to put on weight. So you need to be managing them a bit better. Okay. And so these are all the symptoms suggesting that the patient is estrogen dominant. I touched on it already, and we used the slide before when we spoke about estrogen. So in this client, in that female patient that I just showed you the slide earlier, we used estrogen balance and it improved. Oh, by the way, in that male patient, he chose to use a natural product. Sometimes they'll say, no, just give me something quick. I use anastrozole. I don't like tamoxifen. It causes water retention. And remember, it's a receptor blocker. That means the body's going to try and overcome that blockage and make a lot more estrogen. And so you then have to convince the client that although the estrogen is high on paper, it's not doing anything at the receptor level, but it will still cause water retention and joint pains. And so from that perspective, I like using something where I can show the client the numbers come down. So I use anastrozole, very low doses until I get the level I want. And so here's another client. Look, very estrogen dominant. 600 against 0.4. I mean, for this level of estrogen, we needed a progesterone of 32 to 64. So it's nowhere close to that. Besides, that estrogen is way too much anyway. And so you can see we started using one of that estrogen balance. This remains the same, but this guy started going up. And then when we used two, that improved a lot. Now, sometimes you don't get such a good result. You just have to persist. And if you still don't get it, you need another way to bring that estrogen level down. And you may need to use, and I do off-label use anastrozole lower dose, and you bring the patient from boiling point to simmer. Because as long as that estrogen is high, that patient wants to store. And so a lot of other issues here as well, but don't worry about it. So this was more to demonstrate that if you influence estrogen, you're going to have better results. Here's another client, 27 years. What is a 27-year-old? You know, the estradiol level of 500. I mean, that estrogen dominance is early. Now, why does it happen like this in some clients? Remember that they were a lot more sensitive to the environmental xenoestrogens. It comes from food, it comes in the water, it comes in heavy metals, it comes in insecticides, pesticides. All the animals are pumped with hormones so they can get to the market quicker. And so all these factors, we touched on that previously. And then here you can see we got the estradiol level right down, but very bad progesterone response. And I used this case study, I think last month, 2 weeks ago, whenever, I don't know, but we ended up giving this client progesterone. Important, and then this client also had a thyroid antibody issue as well. And so we worked on that as well. This client, very interesting. Now, again, this is case 7. So I brought this file home. So this patient is 54 years of age and had a thyroid problem and requiring 200 micrograms of altroxin and high uric acid levels, put on Puricos, vitamin D3, 3,000 units by whole again, needed HRT, went on to Estradot 25. We use that patch every 3.5 days. Got her on estrogen balance because her history told me she was estrogen dominant, and we worked on adaptogens as well. But here's the key thing. This client was already put on Ozempic before they came to see me, and they were still struggling to lose weight. And so she was on Victoza before that, and then anyway, GLPs. So here you can see very estrogen dominant. We started working on it, and then I had to use a synthetic estrogen blocker as well. And so what we did here was we put her on adaptogens until she went into menopause. But look at the amount of weight she lost. So when we had her and the other doctors had her on a good thyroid hormone replacement, right amount of HRT, adrenal glands, the DHA was 20 milligrams. Anyway, the long and short of it is, this is a classic example of up to this year, as long as she was estrogen dominant, she wasn't going to lose weight. And now she's gone into menopause. We started off with 25. Now, some of you will say, but 25 micrograms is not going to be enough to get rid of the hot flushes and night sweats that she's going to have now, because she's so used to such a high estrogen level. And you're right. But I always start low, and then I'm going to build it up. And I'm not going to give her high doses, because then the weight's going to come back. How we manage those other symptoms is by using estrogen balance, because that acts as a natural xenoestrogen. It helps the receptor function and works like Livifem, but without the weight gain that comes with Livifem. And so here, a very interesting patient as well. So fatty liver, because of weight issues as well, and fatty liver, in my mind, is from insulin resistance, but also dysbiosis. And the reason why I say that is that, you know, in the 70s, in the 80s, the biggest cause of liver transplant was hepatitis. And now one of the biggest cause is, they say, obesity. But we've had obesity in the past, but we haven't had this much cases of fatty liver. And so in my practice, I see an association with dysbiosis and fatty liver issues. And so when we work on this and on that, then we get much better results. And it's important because your detoxifying pathways, phase 1 and phase 2, in the liver, and that's where the hormones work as well. So I don't have to tell this audience, a lot of you know milk thistle, selenium, very important for detoxing liver. For those of you who remember from the ones who are doctors or nurses, people come in with Bernardo overdose. We infuse high doses of N-acetylcysteine. Remember, N-acetylcysteine is very quickly absorbed and then converted to glutathione, which mops up free radicals. But that is the ace on this particular product. Good dose there as well. Alpha lipoic acids there as well. Good dose of dandelion extract and vitamin E. You can't go to 800 in South Africa. It needs a medical registration. So I know that's the ideal dose, but this one is 400. And so where did we use this product? Here's a client. We had a fatty liver, and slowly it's coming right. And remember, until the GLPs have come on board, fatty liver was always not reversible. And now the GLPs are being registered overseas for fatty liver, so we'll see them coming through. But here, classic example of how you can influence it. And what I do is I use liver balance, but when, I don't know what's happening here. Okay, I use liver balance, and it gives me 750 milligrams of NAC. But when I need more NAC, I just use NAC. And so I think it's Adcock Ingram or Sendos has the one for nasal decongestion. It used to be 200. Now there's a 600 effervescent, but just watch the sweetener in there. Then there's Solal that's got 500, Metagenic 600, or it might be the other way around. And the Hologain brand's got 750. And so you can use up to 4 a day to get to 3 grams. I don't know why I'm not moving. And so, sorry, I'm just stuck. God. Here we go. So here's another patient. I think, yeah, this file I got in as well. So this is one of my Tuffy patients. She's seen 4 endos before she came to see me. And then you always know when they go shopping between your colleagues, you're in trouble. And so again, she's been on 400 different things, on a Simpic, Synjardy, and a bioidentical estrogen for HRT, BIS 7030, progesterone, She's got blood pressure medication. She was on homocysteine balance because she's a poor methylator. And then we were sitting and having trouble with her. But here I think the key thing was that although she was on a GLP, for my colleague, you can still see the extent of the fatty liver. We weren't really winning there. And so once we influenced this, and you could see we started having lots of weight loss. Now, if you look at these numbers, if you just recall and look at the slides I showed you earlier on Contrave, I mean, they're talking about 9%, 10%, 11% weight loss. You look at the GLPs, you know, they talk about 9%, 10% weight loss. I mean, just look at this patient, 93 to 85, after she was given the GLPs and all the other things. So she lost 8 kilos just by influencing her fatty liver. And so from that perspective, the liver is a lot more important than we pay tribute to. Look at this client. There's a male patient. I mean, gamma GT sitting in the hundreds. AST, ALT close to, one is above 100. The other one is close to it, 95. And once we influenced it, with liver balance, it improved a lot. Here's a third client, same thing, using liver balance and having an improvement in, and there were other issues here as well, but let's just concentrate on the liver here. So we've touched on thyroid, besides the forebrain, not forebrain, hypothalamus. We've touched on thyroid and the importance of tightening control there, trying to influence antibodies. We've spoken about cortisol and its importance from a hibernation perspective. We've spoken about the importance of the sex steroids in both males and females. And then what about insulin resistance? So insulin resistance is the cause of prediabetes, which then leads to type 2 diabetes. Insulin resistance is the cause of polycystic ovarian syndrome. So we touched on this in one of the top, I think 2 weeks ago, when we did case studies on diabetes, but some of you were not there. So today I've got a picture of this product, so don't worry, it's coming a bit later. I don't know where, but it's coming. And I promised you guys to get the number for this company. So glucose stabilizer has D-chiroinositol. It has guargam, MENA. It's a fiber that decreases the glycemic excursion, almost like acarbose does, which is a pharmaceutical drug. So it swells up to 200 times its size in the stomach. So you take it before meal. And then that means there's going to be more satiety. The patient's going to eat less. And then whatever is eaten gets mixed with this fiber and gets released slowly. Buttermelon is Kerala. It comes from an Indian fruit, and it is been shown to improve insulin resistance. Cinnamon, 3 grams, has been shown to improve insulin resistance and has actually been shown at that level to improve HbA1c as well. HCA, West African mango, also important from an insulin resistance perspective, and then chromium. So this particular product has everything. I've tried and tested a lot of other products, and they have either that picocetanol, or somebody will have glucochrome, so that and that. Another product will have buttermelon mixed. This guy just has all of them. And I use it because most of the clients who come to me have got big problems. They're not sitting with mild insulin resistance. So this product was made way before berberine came into the market. So berberine also works, not as powerful as your YouTube videos tell you it is. Alpha lipoic acid, in my experience, very weak. It works, but very weak, especially for the kind of clients that come and see me. And then because not told, this guy's got more than that guy, but that guy is just well marketed. Anyway, use whatever you want to. If the patient wants something natural, you got to go, yeah, here we go. So this is what the bottle looks like. It's called glucose stabilizer, and it's got those 6 things that I spoke about. Right. So now this is purely my opinion. I told you guys this. This is not guideline driven. This is not backed by any university. So what about off-label use for insulin resistance? Now, metformin does not drop glucose, so it can be safely used in my opinion, without causing hypoglycemia in most patients on its own. And so in the severe cases, in people who are pre-diabetic, and now it's registered for use in pre-diabetes, I use metformin and get to the bottom of insulin resistance. The gynaes have also been on this for a long time, you know, for patients with trying to fall pregnant. They got patients with PCOS. I showed you guys when we were talking about pre-diabetes, how SGLT2s don't drop sugar levels and actually just makes you pee out sugar, improves insulin resistance, but more importantly, the patient starts getting into a state of ketosis. And that metabolic switch is very important from a weight perspective. And then your GLPs have been registered for obesity. So we've got exenatide and liraglutide low dose registered for diabetes. And then at a higher dose, it's called Saxenda, 3 grams, and is registered for obesity. Ozempic in South Africa is registered for type 2 diabetes. And overseas, the same product in a much higher dose is called Wegovy, and that's been registered for weight loss. And so there are other dual peptides and triple peptides coming along in this oral semaglutide. It's already available overseas markets. One of my clients came to show it to me about a month ago. They're getting it in India, and they already how they got a generic from India, I don't know. But anyway, so even in its oral form. So these off-label or on-label can be used for insulin resistance as long as you tell your client it's off-label and you're willing to take the risks that come with it. But here's a client, 58 years of age, and went from 86 to 70 kilos. Now, if you do the maths, that's close on to 20%. Yeah. And this is somebody who wasn't even very insulin resistant. I mean, if you look at the HOMA index, it's already abnormal. And then we are winning, and then we go off again, as typically you would. Because remember, a lot of insulin resistance, there's a genetic basis off behind it, and then lifestyle messes the client up. So with this particular client, they tried everything. Again, this person came to me from another doctor already on GLP and wasn't working well. By then, I was treating her daughter, and I'm treating her husband. Both of them are bakers. She makes all the wrong things in life, and the husband makes bread. So she's the sweetie one, right? She makes all these pastries and this and then and whatever. But anyway, she's already came to me on tertroxin, half a tertroxin, euthyrox 150, homocysteine balance, and then already came to me on stress damage control. And so, and on a GLP, and still struggling to lose weight. And what was important was that last year she was diagnosed with breast cancer, and she's a breast cancer survivor. And they got it early enough, they removed it, did short chemo, and she was okayed, and she was put on tamoxifen, and so was still having difficulty in losing weight. Now, let's not blame everything on tamoxifen. She was already overweight. She was about 85, and then post chemo and everything, she was 86. All we did here was we stopped the GLP, because remember the 5% rule I told you about? Nothing was happening there. We put in an SGLT2, and look at this. Look at how much weight, and nothing else changed. We never changed a T3, we never changed a T4, we never. So from that perspective, you can see this client's journey has been long. And she's been using a lot of different things. And the end game was, and we were not going to give her DHA. I mean, she had breast cancer. So from that perspective, quite a good result for that particular client. Then this particular case study, 53-year-old, he's an Indian national. Her husband's one of the, who's coming here as a businessman. And then she settled in South Africa for the last few years. And this client came to me with an initial weight of 91 kilos. 91 kilos. And she's been struggling for a while. Post-COVID, she cut down her activity levels. She was affected. A pulmonologist was managing her. But anyway, the long and short of it is look at those, that HOMA index, right? So that's okay, sorry, the HOMA index is covered, but it was 4 point something. And you can see over a period of time, she had remarkable improvement. So she's gone from 91 to 69. Now, she hasn't come back to me for a while. She hasn't come back to me for a while now because she's scared. Her husband told me, because I called her husband, he does decking, and I'm about to deck my garden area. So we chatted and said, you better call her because she's not coming to you because she's scared you're going to be stopping the stuff. And I think she's getting too thin. And look how much weight she's lost. I mean, that's a lot of weight. I mean, that's almost 22 kilos. Now, if you do the maths, that's about 25%. And so from that perspective, here we used a combination product because that on its own wasn't working. But the husband is right. What we need to do is once that HOMA index comes right, we need to influence it. But she's not yet at a point where we need to influence it. We're not going to take it away now. Look at that DHA, 0.4. Much better now. And so there are other issues as well, and we need to work on it. And this tells me that there's a problem with the gut microbiome when that magnesium levels are low. This tells me that, and she was not on cortisol. This also tells me that there was adrenal fatigue. And anyway, so these are just a few case studies, guys, to let you know that although the guidelines are talking about using GLP and Contrave, remember, that's what the pharmaceutical companies are offering you guys at the moment. That's how they make themselves into the guideline. But thyroid's been around for a long time, and we've been managing this thing from the 1920s with glandular extracts until Euthyrox came along by Merck in, I think, 1932. So males, pigs' testes were tied by doctors to humans to get their testosterone levels up. So hormone replacement has been there for a long time. They just, why the guidelines are not emphasizing the importance of some of the other hormones is not for me to answer. But here I'm going to quickly end off by talking about the importance of sleep. So they've shown that if you sleep before 10, you're going to be good. But if you sleep after 10, you're more likely to have diabetes and be overweight. If you don't get at least 7 to 8 hours of sleep, you're going to be overweight or at a higher risk of being diabetic. And if you get to bed before 10 and you're getting at least 7 to 8 hours, but it's interrupted because you're a light sleeper, because you wake up at 2 every day, that's also a problem. So sleep is very important. So now I'm going to show you just a general case. Some of you have seen this before. I think I used it for my first talk to show you that you've got to take a proper look at a client. They tell you, listen, I'm on thyroid medication, I'm not feeling well. Don't just look at the thyroid. It may be other things as well. So here's a complex case where bloody everything's wrong except the cholesterol. So let's start here. The trigs. This client is eating well. You've got to believe them. HDL, shitty, not good. Look at this liver, bloody storing fat. Not good from a cardiovascular risk perspective. Not good from a cardiovascular risk perspective. Highly, not only insulin resistant, but pre-diabetic already. I think it goes on to the next page as well. Just wait. Yeah. So here's that patient I told you. Testosterone, converting to estrogen, adrenal issue, vitamin D. I didn't make this up. You can see the results. Thyroid. Every bloody thing this person wanted to go through all their karmas in this lifetime. So we got the thyroid right, vitamin D went up, adrenals came right, estrogen came down, testosterone came up, fatty liver disappeared. That's easy, Puri course. But look at this result. Look at this. And so this is what true inverted commas anti-aging or preventative medicine is. This is being proactive and improving the entire metabolic status for this particular client. And that was the script. This patient, we didn't use testosterone because fertility was important, but we had to use a combination of things, yeah? So we adjusted the thyroid, improved the fertility, got the testosterone up, came in with the GLP-based therapy, had the patient on metformin. I used liver balance for the fatty liver. We got that vitamin D up. We gave them the DHA for that adrenal issue. Patient didn't want anastrozole, and so we used an estrogen balance and got that vitamin D. So here, the vitamin D was a natural source. You know, they reckon the daily requirement is 800. I've never managed to get any patient right on 800 international units. Goals of therapy. So remember, you get most of the guidelines, no, not most, all the guidelines are bone specific from a reference range perspective. Because in the past, 30 years ago, they thought vitamin D was only important for bone and osteoporosis. So it's a bone specific reference range. That's why it speaks about sufficient or not sufficient. We've never used that terms anywhere else before. However, you got metabolic conditions, hypertension, obesity, diabetes, I aim for 50 to 60. If you've got autoimmune conditions, I aim for 60 to 70. If you've got cancer, I aim for 70 to 80. So that's when you're starting to kick in the immunomodulatory properties. And so I always say try and use a product that doesn't have Ceph oil or omega-6. A lot of them use omega-6 as a carrier molecule because it's cheap. This particular one is 3,000 units and it's no animal products. I think I've used this example before to you guys. This wasn't my patient. This was Dr. Ahmed's patient, somebody who is a regular on our webinars and was on calciferol and changed over, and look what happened. I think I've done this one before. Okay, case number 13. Yeah, so this is my last case. Again, multiple issues. She's a food stylist, this woman. You know, people have such interesting careers. So that's the adverts you look at, and that ice cream looks so good, and then you realize that it's a fake. Or you look at mayo on your advert, she tells me, and it's actually whipped cream and stuff like that. So they make food looks good for adverts. But this patient lost from, sorry, I was about to sneeze there. From 85 kilos, she went down to 68 kilos. So she lost 17 kilos. And we had to work on quite a few things here. So we worked on the antibodies. We worked on the estrogen dominance. And we worked on an insulin resistance as well. Now, let me just try and remind myself why this case was interesting. Okay. So she is 46 and she's not in menopause. She's not in menopause. So here you could see we were starting to get the ratios right. And then it started going wrong. And so here, what I did was I actually put her on a contraceptive. So a contraceptive supposed to switch you off, and hers wasn't being switched off. That tells you how estrogen dominant she is. We had her on estrogen balance, and then I gave her anastrozole as well. In other words, I blocked her estrogen. I blocked her estrogen completely, like a contraceptive supposed to, right? But at 46, she had too much. And what we did is we came in with anastrozole. And so anastrozole switched it off. And so you would say, but now she's going to get hot flushes and night sweats. No, she's getting a fixed amount of estrogen in her contraceptive. And that then sorts out her estrogen progesterone issues. But there we were desperate because we were not winning. And look what's happened. I mean, again, I don't know, if we do the maths, that sounds like a lot. That's what, 17 kilos. So that's exactly 20%. That's, so you can see now that in most of these cases, the weight loss is beyond that 5 and 10 and 11% that you look at in terms of what the studies have been showing. And that's because here we used a few nuances in trying to work on some of the other things that the guidelines are not yet pointing to. And it comes easy to us because we endos, so we know we need to work on these hormones. But my second last slide now. So I want to end off by talking about the set point. So we are all born with a set point that determines our size for our pancreas, our liver, our heart, whatever. And our hypothalamus at 18 has a set point for weight. Many things can affect that set point. There can be dietary things, there can be unhealthy ways of building quick muscle using anabolics and then coming off it. There can be sleep deprivation, there can be stress. There's many things, drugs that can influence a set point. But once you have a set point, the body is always going to try and defend it. And the problem is, if you were always 60 kilos and then slowly you move to 70, it starts liking the 70 because it thinks 100,000 years ago, when there wasn't a spa, now it has better stores. So it likes it and it's trying to defend it. That is why weight loss is a challenge. You get the client, the weight is here, they lose and they say, hey, I'm stuck now. 2 months I'm stuck, the thing is not moving. Stay there, carry on with the activity, carry on watching your carbs, carry on doing whatever you were doing, carry on with the meds, and it should drop again. And then it will get stuck again because it's defending the next set point and so forth. And so you've got to wait through the hard times because that's how you're going to be influencing it. So each one of these things has a way of improving those set points. But the longer you stay at the new set point, hopefully it's a lower set point, the more likely the patient's going to be able to defend that particular spot. Otherwise, like that slide I showed you, it's very easy to get a client to lose weight with diet and exercise. This shit is going to come back. It's going to come back. And so, in conclusion, obesity is a set of complex, it's chronic, many pathways. It has an important and enormous impact on individuals and on healthcare systems and on society. It needs personalized medicine, the right treatment for the right patient. So I'll be in trouble if I don't put the slide up because Leonie is going to be on my case and on your case. Some of you have seen this range of products, and I'm going to stop there for any questions. So I've asked you guys, so some of you guys have been very active with Leonie. I mean, I've got a doctor who regularly sends me an email every 2 or 3 days with questions. I get some of you sending me your cases. So don't be shy because you guys got to send some of the cases. And some of you guys are sending me wrong cases. Send me cases that whatever the webinar is advertised for, because otherwise you feel I'm not going to be answering your case and it's going to be gone too far gone. So the adrenal ones are coming and the gut microbiome ones are coming, but it makes it interesting for all of us if you guys bring along some case studies. So now I can't see all the questions, so I'm going to get out of this. Right, here we go. And so let's see if there's any questions. So any questions? Yeah, here we go. Where and how can we listen to the recordings? Actually, recordings. So there's the email from Leonie on the bottom of your chat group. You can get hold of her, and I know she has been sending some of you guys who've requested the recordings who wanted to watch it at your own pace, which is completely fine. Let me see if I can find other questions. But otherwise, just unmute and ask me questions. I see we got some endos, some nutritionists, some physios, OTs, dietitians. Just a question, Dr. Bana, do you find cortisol blood tests accurate enough, or would you do saliva? Okay, so I use my cortisol levels between 6 and 9 a.m. in the morning. Saliva is very good as well. Saliva maps out the day for you. So you can get 4 or 6 aliquots they spit in it every 3 or 6 hours. As long as they've registered it, you can actually map the circadian rhythm. So that's good as well. Cumbersome, a bit more costly. And then a 24-hour urine helps me when I keep measuring it, and sometimes the patient's on a contraceptive or it's high, and you measure the 24-hour urine, and if it's well within the range or it's low, then you can tell the client, listen, it's just a morning thing, but most of the rest of the time it's fine. So the test I use is very dependent on what's happening with my client. Certainly for my overseas clients, I've got lots from Europe and UK, they give me saliva. What ratio of estrogen progesterone are we wanting? So Deline, I think we covered that with one of our other estrogen dominance talks. So if you just ask Leonie to send you the recording, it will be there, but just generally speaking. So in the first half of the cycle, the majority of females on this planet should be averaging an estradiol level of 200. Second half of the cycle, they should be averaging around 350. Now, they may be more, and the progesterone is meant to match that. So in the first 14 days, I want the progesterone to be at least 1/10 of that. So in other words, if the patient's got a level of 200, that progesterone needed to be at least 10. In the second half of the cycle, if the person measured it in the second half of the cycle, and let's say it was 500, and then you want at least 1/10 of that, so it has to be 50. So in other words, I do it any time of the month. So let's say they did it day 18, and estradiol is progesterone is 0.8, and the estradiol is 400. Well, you don't have to do the maths. The ratio is off already. Because remember, your maker and the patient is not doing all of this for things to be perfect on day 3 or day 21. That's what the gynae wants. That's what they've been taught to measure it on those days. So I get told by my patients all the time, the gynae told me that you measured it on the wrong day. There's no wrong day. The sun gets up every day and the female's estrogen is working every day. It doesn't only work on day 3 and day 21. So hormones are about ratios. You don't measure insulin only on a particular day. You don't measure. So these things are all about ratios. So that's the ratio I use. 1/10 estrogen progesterone ratio for the first 14 days, second 14 days, 1:20. So that's where it must fit in. What are your thoughts of reverse T3? Yolandi, your patient's got a lot of money. So yeah, reverse T3 is good. And you know, in the 70s and 80s, I don't know, Prof. Song, I think registered, I don't know if he's online, he'll tell you, and they used to teach us, those days, every patient used to get a reverse T3. So the role of T4 and T3 and reverse T3 is beautifully explaining what happens during hibernation. So if the body feels there's too much T3 because I'm sick, because I've got cardiac failure, or I'm in starvation mode, or I've got too much T3, it's going to dump it to reverse T3, and that means it's not going to be used. And the enzyme pathways are very dynamic. It's going to be doing that. So it's a nice test to prove to some people that they own too much T3, because I think I like using T3. I think there's a place for everything, but the abuse of it becomes a problem, and then you're just going to end up dumping it. So it's a very expensive test. It takes a while to get back, but helpful in those regards, and especially with what we call sick thyroid. Can you use estrogen balance for deficiency states also? Yeah. So estrogen balance acts as a natural xeno estrogen, and so it's like Livifem without the weight gain aspect to it, and so it will decrease or get rid of hot flushes, night sweats, but not vaginal dryness. It also helps pigmentation issues that you see in the perimenopausal state. Some women will tell you that they're getting ochronosis and all of that because it acts as a xenoestrogen. Its main function is to decrease estradiol, E2, to go to E1, estrone, because we spoke about this 2,4-hydroxyestrone. So 4 and 16-hydroxyestrone is not good for breast cancer, fibroids, and endometriosis. And I think I told you guys that there's a prof in Potchefstroom that measures this for your clients. So yeah, it can be used in deficient state. Hi there, I have to leave early. Oh, okay. Yeah, so there's a recording. All right. Any other stories, guys? Any other questions? Oh, is cortisol useful to test in prepubertal individuals? Yeah, I mean, you know, nowadays, I treat this family from Benoni, and he's in his early 60s, and he married a young lass. Good for him. She's about in her 30s. And now I kid you not, they've adopted 8 children. And so the cutest children on this planet, they come and see me. And it's amazing. So whenever they adopt a kid from a home or from a family or whatever, they bring the kid in for screening. And I tell you, every one of these kids had adrenal burnout. They come with these sunken eyes like I've got. They've got that shallow look. And it's so nice to see over the months how the adrenal improves. So I don't like to see children. I think they must go and see Ajay Chiba, who's a pediatric endocrinologist. But when the client is not happy or they can't get in or whatever, because it's a shame the poor guy is very busy. I mean, there's so many type 1 patients. Then I have to see these prepubertal individuals. But yeah, I do look at both the DHA and cortisol on those patients. What is the ideal level for the male testosterone? So remember, some estrogen is needed in males because it's important for bone health. And then I did a talk this year, the IVF conference invited me this August to speak as well. And I showed them slides and studies in terms of how a little bit of estrogen is important for sperm production and fertility and all of that. So I aim for levels of between 60 and 70. I know it's quite tight. Above 90, I'm not too happy. So yeah, it's about that ratio, but you get your patient below 90, most of the time you're going to be fine. What is this 10899? I'm not sure about what that is, right? Oh, sorry, that's a number. Please specify what the ideal ratio of cortisol DHA. I think we're doing adrenal next, so let's leave it for that. What is the difference between T3, T4 versus free T4? Oh, okay. I don't know. Did we do something on thyroid, a webinar? If we didn't, then we must do one from the line of questioning. So free, any hormone that is free is not bound to albumin. So it's exactly what's available to the tissue to be used. Whereas something that is not free, whether it's free cortisol, free testosterone, free T3, is bound to the transport molecule. So these are binding globulins. You get cortisol binding globulin, you get sex hormone binding globulin, you get thyroid binding globulin, and so some of it will be held on. So especially for pregnancy, it's the free T4 that is more accurate. What are the indications for testing estradiol levels in males? So when they come with gynecomastia, when a teenager comes with stonies, tenderness and a bit of breast tissue, males that are given HRT, and then you find that they're developing breasts, libido issues. These are all important. But I test it when I get males with fatty liver as well, because when they got a fatty liver or they got severe dysbiosis, testosterone is going to be converted to estrogen. And so it depends on your scope of practice. As an endocrinologist, God, I do it in a lot of my patients, but it depends on what your scope of the practice is. But that would be the indications, the ones I've just mentioned. Is there a role for intermittent fasting? Yeah. I think we've spoken about this before as well. I mean, my wife and I do intermittent fasting. So many people do intermittent fasting for different reasons. So just purely from a weight perspective, Remember, simple equation. You eat 3 times a day, you do intermittent fasting, you have in 1 or 2 meals. It's always more difficult to fit what you were eating in 3 meals in 2 or 1 meal. So just simply by that means you're going to eat less calories. But the real reason why I like intermittent fasting is, I spoke about it before, is that the body learns how to do what we call a metabolic switch, where it learns how to use ketones more efficiently and not only glucose, because we are all addicted to glucose, right? And so most people will take about 5 to 7 days to get to a state of ketosis. And you can measure with the sweet breath, or test your urine and you'll see ketones, and then you know, right, you're in a state of ketosis. However, the longer you do intermittent fasting, you'll find that it's easier for you to switch from using glucose and ketones. And so certainly for me, it's helped my reactive hypoglycemia. For the ones who know me, know that I had to always be munching every 3 to 4 hours. Last couple of years, it's easy. I can go without a meal for 18 hours and I'll be fine. Not all days, most days, but and then there's other benefits as well once you go into a state of ketosis. But that's a talk one day when we talk about cancer cells and apoptosis. But yeah, I think intermittent fasting is not a bad way to go. If you think about it, 10,000 years ago, we were all doing intermittent fasting. You never had 3 meals a day. There was no way you could store food, right? There was no grains 10,000 years ago. They came into the picture 6,000 years ago. There was no Spar. There was no Woolworths. There weren't orchards of fruit or fields of maize and corn. You speared an animal and you ate it and you couldn't store it. There was no biltong then. You couldn't smoke and store. So from that perspective, the lion is always doing intermittent fasting. And so were we. We adapted in time when we moved from hunters and gatherers to a more farming society, and then we started storing and so forth. So I think I would argue our natural state was always intermittent fasting. All right. So I think we've spoken long enough. I'm sure some of you guys need to go to your families. Thank you guys for attending. And any questions, send them to Leonie, and when I have time, I'll try and answer it. And if there's anything else you guys would like in the field of endocrinology, suggest it to Leonie, and then we can have webinars on it. And thank you. Thank you, guys.